When we're sick, we take a drug and we get better. But how does the drug accomplish that? Do all drugs work in the same way? If we take a drug that increases our heart rate, what does the drug do when it arrives at the heart muscle? And if we take a drug that decreases our heart rate, in what way is it working differently from the drug that increases the heart rate? Sometimes a new drug comes and we are told that it's better than the current drug. In what way is it better? And sometimes we hear people say that this drug is very potent. What does that mean? I'm William Lim. Join me in this video lecture on pharmacodynamics for nursing students. We use drugs for many important disorders. From asthma to diabetes to depression, many important disorders are mainly managed by drugs. Hypertension and dyslipidemia are very common cardiovascular conditions treated by drugs. For movement disorders like arthritis and Parkinson's, drugs are also the mainstay of treatment. If not for antibiotics, most of us won't be here today. And can you imagine surgery without analgesics or anesthetics? We use drugs for major disease such as cancer. We also use drugs when we have constipation or diarrhea. Drugs is an important part of our lives. So what happens when we give a drug to a patient? The drug has to travel to the site of action, whether that's the heart or the brain or the leg. The drug has to get there. But once it arrives at the site of action, then it produces the effect that we want. Pharmacodynamics is the study of how drugs are absorbed and distributed, metabolized, and excreted. In other words, what the body is doing to the drug. Whereas pharmacodynamics is about what the drug is doing to the body, how the drug produces the effects in the body that we want it to produce. So we see the patient taking the drug, and later we see the patient getting better. But what happened in between? How did the drug produce its effect? Now let's consider how some drugs work. If you have hypokalemia, you might be given a potassium supplement. So it works by adding more potassium. If you have heartburn, you could take this antacid. It contains alkalis that can neutralize stomach acid, so it reduces the acidity of the stomach. One of the treatments for infectious diarrhea is activated carbon. So it works by binding to toxins and microorganisms so they can be excreted out. And if you need to have a bowel movement, you might be given a sodium phosphate enema. It has high osmolarity, so it draws water from the colon, and this stimulates our bowel movement. So it's simple to understand how all these drugs work. But most drugs don't work in these ways. Most drugs work by first binding to a receptor. In 1905, British physiologist John Langley first proposed that drug binds to a receptive substance on the cell. And that was the beginning of the receptor theory for the action of drugs in the body. The surface of cells are embedded with different kinds of receptors. These are proteins on the plasma membrane. Most drugs bind to such receptors in order to produce an effect. A drug don't bind to every type of receptor, but only to those that it can fit. Much like a key can only fit into the correct lock. Once a drug binds its receptor, the receptor changes shape and produces the effects in the cells. This is like once the key in the lock is turned, then the door opens and the people can come in. What do receptors look like? Let's take a look at two examples of receptors. Adrenaline that is released by the nerves or that we inject into the bloodstream works by first binding to a receptor. It binds to a receptor that belongs to the family called G-protein coupled receptors. When adrenaline binds to the adrenergic receptor, the receptor is activated, and then G-proteins dissociate and bind and activates other cellular proteins. The activation of these cellular proteins initiate signaling pathways that eventually leads to the cellular responses. Now, as a second example, we're going to take a look at lignocaine. Lignocaine is a local anesthetic, and it reduces pain on the skin. And it works by binding and blocking a receptor called an ion channel. For nerve cells to convey the pain sensation, these ion channels have to open to allow sodium ions to enter into the nerve cells. The way lignocaine works is that lignocaine binds and blocks this sodium channel so that these sodium ions cannot enter, and therefore the pain sensation cannot be transmitted. So then most drugs work by first binding to a receptor. And now let's discuss the concept of drugs having an affinity for its receptor. When you walk into a food court, you go for the food that's your favorite. If you like Korean, then you go for the Korean store, not the Western, because you have an affinity for Korean food. Likewise, every drug has an affinity for its own receptor. I'm going for the Korean food. Every drug has an affinity for its receptor, and this is because the receptor and the drug has physical characteristics that make them fit into each other. And I illustrate it here by showing the shape like drug A fits into receptor A because it's a triangle, and drug A doesn't fit into receptor B because receptor B is a square. So each drug will have an affinity for its own receptor. So the way drug meets receptor is much like how people meet together at a party. So at a party, you talk to a person, and after a while you move away and talk to another person, and then you talk to a different person. So the drug and the receptor are moving randomly, and when they get close to each other and there's affinity, so then the drug will bind to the receptor. And you can see here, free drug and free receptor meet each other, and now drug is binding the receptor, indicating the DR drug complex. And when the drug binds the receptor, the drug activates the receptor, then that's how we get the effect. But just like in the party, the drug doesn't bind the receptor permanently. After a while, the drug will dissociate from the receptor and leaving the receptor empty so that another drug can bind that same receptor. So you go from left to right to form the complex, and then the complex dissociate and you go from right to left again. So then when the drug and receptor collide randomly, they will bind to form the drug receptor complex. But after some time, the drug can dissociate from the drug receptor complex to become free drug and free receptor again. So now let's think of representing this in terms of a curve, a drug receptor binding curve. So here we're saying that you can do an experiment where you add more and more drugs, so the dose is being increased from left to right. And the more drug you add, the more binding there will be of the drug to the receptor. And you can measure the binding using biochemical or biophysical methods. You can measure how much of the drug is binding the receptor. So you can see that what the result you expect to get is that the more drug you put, the more binding you get. And then eventually, you get the curve reaching a plateau, meaning that if you put even more drug, you don't get any extra increase in binding. That's because you have put in so much drug that you have bound all the receptors. When all the receptors are bound, then there's no more increase in binding, even if you increase the dose of the drug. So the curve increases until it reaches a plateau, and we call this type of curve a rectangular hyperbolic curve. So that was a experiment to measure the binding of the drug to the receptor. The other important kind of experiment and curve that we want to do is called a dose response curve. So now we're looking at the drug binding, the green drug binding the green receptor, but we're not measuring binding. In this experiment, measuring the effects of the binding. So after the green drug binds the green receptor, it activates some intracellular processes, which then releases calcium, shown by the red dots. So the release of calcium in the cell is a response of the drug binding and activating the receptor. So in this experiment, we want to measure the drug causing the response. So it looks like. So once again, the more drug we put, we can see that the more response we get, right? Because the more drug bind, more receptors producing more responses, which is the release of calcium. Eventually, when you give a lot of drug, the responses doesn't increase anymore because you have occupied all the receptors, or else you have caused all the receptors to be activated to give the maximum response. And then if you give even more drug on top of that, you will not get any more increase in response. So here we get, again, we are now seeing a curve which is based on increase in drug dose and on the x-axis, and the increase in response on the y-axis. And once again, the shape of the curve is a rectangular hyperbolic curve. And we are actually plotting D, which is the drug we add, and then we're against response or effect that we see after addition of the drug. So the kind of curve we saw just now had this kind of shape, the rectangular hyperbolic curve. But in pharmacology, the more common way we plot the curve is by plotting a x-axis. We modify it from a linear scale into a log scale. You can see now on the right hand side, the x-axis is now in the log scale, which increases exponentially, not linearly. And when we change the x-axis in this manner, we find that the shape of the curve changes to what we call a sigmoidal curve. And this is very useful because the middle part of the curve is now linear, making it much more easy to interpret, whereas the early part of the curve, it is now more spread out instead of being compressed as over here. So in pharmacology, this is the most common way for us to plot the drug curves, and we do this by plotting a semi-log scale for the x-axis, and then the curve is called a sigmoidal curve. Okay, we often hear people talking about the word potent, and people say that a certain drug is very potent. All right. So what do you think is the meaning of this word potent? What does it mean when a drug is potent? So now let's consider the topics of potency and efficacy. Okay, so let's look at these two drugs. We know about morphine, right? It's a very important analgesic used for strong pain, and petadine is also very important analgesic as well, and both can be given through IV injections. Let's look at the dosing. So for morphine, the dose is about 4 to 10 milligram every 4 hours. But for petadine, the dose is much higher. It's like 25 to 100 milligram, also every 4 hours, to achieve the same effect. So to achieve the same effect, you have to give more petadine as compared to morphine. So in this case, we are able to compare the potency between two drugs. Now we are graphing the dose response curve of morphine as well as petadine. We can see that as you give more drug, as you increase the dose, you get more response until you hit a maximal response. You can see that both morphine and petadine are able to give a maximum response. But it's just that you need to give more petadine
to give the same response as morphine. So normally we take the 50% response as the reference. Okay, so if you look at the 50% response indicator here, and you look down on morphine, you find that about 10 milligram dose of morphine can give 50% of the maximum effect. Whereas if you look at the 50% for the petidine, it's about 100, right? So which means that you need to give 10 times more petidine to get the same effect as morphine, right? So in this case, we say that morphine is more potent than petidine because you only need less morphine to give the same effect as petidine. In fact, 10 times less. So potency is the amount of drug, the dose concentration, or the amount of drug that you need to produce a certain response. Usually we take 50%, right? So potency can be used to compare between two or more drugs. So in this case, we say that morphine is more potent than petidine by comparing the 50% response. So we know about this analgesic called paracetamol or acetaminophen, but there's another preparation, it's actually called Panadine. Panadine actually contains paracetamol or acetaminophen plus codeine, right? So there's an extra analgesic here, codeine, added to paracetamol, and you can buy this over the counter. So what is codeine? Codeine is a drug in the same family as morphine, but it's bought over the counter, so it's not that strong. So if you use codeine in strong pain, you will find that the patient will still complain of pain. Whereas if you give morphine, then the patient will be relieved of the pain. So if you plot the dose response curve of morphine compared to codeine, you find that the codeine levels off here. And so it cannot produce the same maximum response as morphine. So the concept here is the concept of efficacy. Efficacy is the maximum response that a drug can produce in a given system. Of course, we assume that you have given enough drug so that all the receptors are bound or you are giving maximum effect. But once you have given enough drug, you measure the maximum response. And if codeine gives a lower maximum response compared to morphine, then we say that codeine has a lower efficacy or morphine has a higher efficacy. So then we put the three drugs together. We saw that morphine and petidine had the same efficacy, whereas codeine had a lower efficacy. And in terms of potency, you can see here that if you look at approximately 50% level, morphine clearly is more potent than petidine because you only need less morphine to achieve the same effect. Codeine is somewhere in the middle, so the 50% line for codeine is here, and so codeine is somewhere in between the potency of morphine and petidine. Let's use this as an example, and we ask ourselves, if given these three drugs A, B, and C, if this is the dose response curves, let's rank the potencies of the three drugs. So to look at the potency, we look at the 50% effect and look down at the dose. So we can see that clearly drug A is the most potent, followed by drug B, followed by drug C. So A is more potent than B, is more potent than C. Compare the efficacies, clearly drug C is the most efficacious, right? And then A is equi-efficacious to B. So C is the greatest, has the greatest efficacy, whereas A and B are equal. Let's take another example. So now in these three drugs A, B, and C, let's rank the potency. So drug A is the most potent, followed by drug C, followed by drug B, right? And in terms of the efficacy, we can see here that drug C clearly is the most efficacious, followed by drug A, followed by drug B. So now let's think about this concept of potency and efficacy. Sometimes people come to your hospital and introduce a new drug, and they say that our new drug is more potent than your current drug, right? So just think of what's the meaning of potency. And so you have to make this decision. Should your hospital buy in this new drug to replace your current drug because this new drug is more potent. So should you buy it or not? But you may want to ask other questions, right? But how about the price? How about the side effects? Let's make it simple and say that everything else is the same between these two drugs. The same price, the same side effects, the same dosing frequency, just take once a day. Everything's the same. Nothing's different. The only thing that's different is the potency. So then, if the new drug is more potent, should you buy this new drug to replace your current drug? So to answer this question, we need to think like from the patient's point of view. Do you think the patient would prefer a drug that's more potent? Or what is the criteria for the patient? What do they really want? Are they more concerned about potency, or are they more concerned about efficacy? So think along this line in order to make a decision based on what you understand about potency and efficacy. Right, let's now go to the topic of agonist and antagonist. Okay, an agonist is a drug that binds to a receptor and produces a biological response. We've been seeing so far agonists because like when the green drug binds to the green receptor, that activates the receptor and we see the release of these red dots, the calcium. So obviously this drug, green drug, has activated the receptor to produce the calcium response. So in that case, the green drug is actually an agonist. So the dose response curve here shows that the more of the green drug you put, the greater response you see. So this is an agonist because it's a drug that can bind to the receptor, produce a response, all right? We see the response and we assume that the drug is binding to the receptor to produce that response. Full and partial agonist. So if you look at drug A versus drug B, you find that drug B cannot produce the same amount of efficacy compared to drug A. So in this case, we can call B to be a partial agonist in this system. A partial agonist is an agonist whose maximum response is lower than that of the full agonist. And so A then, in this system, represents a full agonist because it produces the maximal response. Now, what is an antagonist? An antagonist is a drug that binds to a receptor but produces no effect. So we can see here, antagonist represented by the orange drugs. It binds to the green receptor, but there is no release of calcium. There is no response. It does not activate the receptor. If you look at the dose response curve, and the yellow, the orange line represents the antagonist, even though you put in a lot of an antagonist, but the response is still zero. That's why the line is flat. So this is a drug in which it binds the receptor but produces no response. So that's an antagonist. So then on this dose response curve, you can see drug A, which is the agonist, it increases the response. But drug B is the antagonist. No matter how much drug B you put in, there is simply no response. So you ask, then what is the use of an antagonist? It binds the receptor, but produces no response at all. That means that it binds the receptor, but it does not cause the receptor to change its shape. So the receptor remains inactive. It does not activate. But there is an effect on the receptor. Because when the antagonist is binding to the receptor is occupied. And so the receptor cannot bind an agonist. So one effect of having an antagonist binding the receptor is that the antagonist prevents the agonist from binding the receptor. So what use can you think of this, an antagonist? Let's use this as an example. For example, morphine is a very important analgesic, but sometimes if you take an overdose of morphine, then it can result in coma and death because of the side effects from excess morphine. So if a person takes an overdose of morphine, then a lot of the opiate receptors will be binding to the morphine, which produces the response, and then the response will be in excess, which is dangerous. So what is one way to treat a morphine overdose? One way is to give the drug called naloxone, which is an opiate receptor antagonist. right? And giving an antagonist instead of an agonist. You know, antagonist will bind the receptor, but produces no effect. So I want to ask the question, if you have a patient in morphine overdose, and you want to give naloxone to rescue the patient, naloxone is the antagonist, what kind of dose would you want to give to the patient? Do you want to give the naloxone in a very low dose or a very high dose in order to rescue the patient? We'll say we'll give a high dose, right? You say you want to give a high dose. Right, let me illustrate it in this way. If you're in a crowded train like this, and some people are seated and some people are standing, but the moment someone who's seated gets up and the seat becomes empty, then a person who's standing will sit on the empty seat, right? That means that nobody sits permanently. There comes a time when the person seated will get up, and when the person gets up, the seat is empty and somebody will then sit down on that seat. And this is the same for drug. The receptor drug will bind the receptor, but it doesn't bind permanently. After a while, the drug will be released from the receptor, right? And then when it's released from the receptor is available for a different drug to bind. And that's how naloxone are rescued from morphine poisoning. Let's think of the purple drug as the morphine and the yellow drug as a naloxone. So when the morphine leaves the receptor, then the most likely drug that will bind the receptor would be naloxone, the yellow naloxone. As this assumes that we give the naloxone in excess compared to the morphine. We give a very large dose of naloxone so that whenever the morphine leaves the receptor, the next drug to bind is more likely the naloxone. And when the naloxone binds the receptor, it doesn't activate the receptor. And so after a while, you find that most of the receptors are occupied by naloxone. And therefore, the patient then recovers from the effects of morphine because most of the receptors are not binding to morphine, but now most of the receptors are binding to naloxone, the antagonist, because you give the naloxone in a very high dose. Now let's consider reversible and irreversible antagonists. So just now we said that the morphine leaves the receptor and naloxone comes on. Therefore, morphine is binding reversibly. It doesn't bind permanently. It leaves the receptor. And naloxone also is a reversible antagonist. After some time, naloxone will also leave the receptor, giving a chance for either naloxone or morphine to bind that empty receptor. So both naloxone and morphine are actually drugs that bind reversibly. And in fact, most drugs bind reversibly. We assume that drug is binding reversibly unless you're told it's not. So naloxone is a reversible antagonist because it can leave the receptor after some. So a reversible antagonist or surmountable or competitive antagonist are antagonists that can dissociate from the receptor after bound. Whereas an irreversible antagonist or an insurmountable or non-competitive antagonist are those that cannot dissociate from the receptor after binding. So once they bind to the receptor, they will not let go of the receptor. That means that that receptor is no longer available for any other drug except the antagonist that is binding permanently. Then we ask the question, when do you want to use an irreversible antagonist? Because this drug will bind the receptor and not release, and it will be permanently binding to the receptor. For this one used for a drug like this, let's get an example of this tumor called pheochromocytoma, which is a tumor at the adrenal gland, and it results in the excessive production of adrenaline, right? And when you have too much adrenaline, then the body will get hypertension, increase in heart rate, sweating, tremor, and all the sympathetic effects from the adrenaline. So when a patient has too much adrenaline because of this tumor, one way to treat it is to give the drug called phenoxybenzamine in order to control the blood pressure and the sweating and the tremor and all that. So how does phenoxybenzamine work? Phenoxybenzamine is actually adrenergic receptor antagonist, alpha antagonist. So adrenaline will bind to the alpha adrenergic receptor. Phenoxybenzamine will also do that. But phenoxybenzamine is an antagonist. It will not cause activation of the receptor. Furthermore, phenolphthalein is an irreversible antagonist. Once it binds to the receptor, it forms a covalent bond to the receptor, and it cannot leave the receptor. And that is important in pheochromocytoma, because in this tumor, you have just way too much adrenaline in the body. So what you need is not an antagonist that will bind and release, because if you release, then the next drug to bind is adrenaline. So phenolphthalein is irreversibly binding. So once it binds, it will not leave the receptor, so that will leave much less receptor available for the adrenaline to bind. And because there's too much adrenaline in the body, this is a way in which you can reduce the effects of adrenaline. So by using an irreversible agonist.